I'm going to talk about actually a paper that was just recently published in the Journal of Allergy and Clinical Immunology in Practice that goes by the same title in collaboration with my colleagues listed. I have nothing to disclose. Food allergies are prevalent in our general pediatric population at a rate of about 4 to 8% of kids. This equates to be about 3 to 6 million children within our nation's population that have a documented food allergy. And this rate has really been on the rise over the past 10 to 15 years by a margin of more than 20%. Younger children are most affected, as some food allergies do resolve before the age of 5. However, many allergies persist throughout the lifetime. And there's a high burden of disease with more than 300,000 combined ambulatory and ED visits per year in our country. And while food allergies have a low mortality rate, they do remain life-threatening. There have been several well-publicized cases of death from food allergies in pediatric patients over the past several years, and a quick Google search provides the following examples. This one actually happened this past Thanksgiving, and these two examples happened in camp settings. There are a lot of children who attend camp every year. However, there are no standard national guidelines for the management of food allergies in summer camps. Such guidelines do exist for school settings. However, we know that camps and schools are very different. And there isn't a lot of research in general on medical care in camp environments. Previous studies that have been done have been small in sample size, been limited to rates of injury or illness outbreaks, and have been in specific camp populations as opposed to the general camp population nationally. So why are camps different? They really are a unique environment that can make the management of food allergies and other medical problems challenging. There are increased supervisory ratios, and the people who are supervising have a very variable medical background. Your typical camp counselor ranges in age from 18 to 24, and any medical experience they have tends to be from personal experience or any training they may or may not have received before starting their job. The risk of exposure is increased due to increased opportunities for food sharing, cross-contamination, and menu variance from home that's inherent to any place where you're mass producing and mass consuming food within a cafeteria or a mess hall, regardless of how much supervision there is. And many camps are located in remote locations away from emergency medical services, or they do excursions to remote locations. And this can make care of allergic reactions challenging due to delayed care or definitive management if a camp is not otherwise prepared. The legislation for the allowance of stock non-prescribed injectable epinephrine is also variable. Schools nationally are allowed, and many states actually require schools to have injectable epinephrine available for non-prescribed use after President Obama signed legislation in 2013. This was seen important, much like having AEDs in school, given the unpredictability of food allergic reactions. However, camps and other recreational entities were not necessarily included in this legislation, and that's been changing over the past 12 to 18 months, with now 23 states that allow camps that same privilege to have stock not prescribed epinephrine available for use. However, many camps are either private or nonprofit in nature, and they don't necessarily have funding to cover health and safety related expenditures. So our research question was to look at this unique population and assess the current state of the problem. That was our primary objective. Our secondary objectives were actually twofold. The first was to assess the extent of asthma comorbidity, given that this is a known independent increased risk factor for severe anaphylaxis, as well as to determine the epinephrine autoinjector prescription presence on medication list, given the variability in statewide legislation. These were hypotheses that our food allergy prevalence would be about the same as the general population, so 4 to 8%, and that less than 50% of kids would actually have an Epi autoinjector with them at camp. We had a cross-sectional design and partnered with campdoc.com, which is a leading web-based EHR for camps utilized across the US and Canada. And at the time of our study in 2014, there were over 170 camps enrolled which represented over 120,000 campers, and this number has significantly increased to date. We looked at food allergies, excluding those listed, in order to try and get as close as possible to type 1 IgE-mediated disease. We looked at asthma status, medication list, and then documented age, gender, region of the camp, and camp type, whether it was an overnight camp or a day camp. Our data were analyzed and we did chi-square calculations. And our results were that we found in our population, 2.5% of campers had a documented food allergy. And this is slightly lower than the national prevalence that I discussed earlier of 4 to 8%. When we looked at type of food allergy, we found that nuts were most prevalent, followed by seafood. And this is also slightly different than our most recent national data, which comes from the 2013 NHANES survey, which showed milk in highest prevalence, followed by nuts. In our population of food allergic campers, 22% had multiple food allergies. 44% were at theoretical higher risk for severe anaphylaxis given their comorbid asthma status, and 35% of those asthmatic patients were on multiple asthma medications. However, only 40% of food allergic campers actually brought an epinephrine autoinjector with them to camp. And this was our most striking result. So we wanted to look at whether or not there were any predictors of whether a child would be more likely to have an autoinjector on their medication list. And what we found that having a diagnosis of asthma actually increased your likelihood of having an injector. And possibly that's reflective of the notion that asthma is an increased risk factor for severe anaphylaxis. Similarly, staying in an overnight camp was associated with an increased likelihood of having an injector as opposed to a day camp. However, rates of autoinjector presence were similar by region. The differences between them approached but did not reach statistical significance, and I think this has interesting implications when you think about the legislation variation by state. So our conclusions were that food allergies and comorbid asthma are prevalent within our national camp population, albeit at lower rates than the general population seen previously. Highest allergy rates were seen to nuts and seafood, but a substantial portion of food allergic campers did not bring epinephrine with them to camp. So our biggest interest for our next steps now are in emergency preparedness and training. We actually performed a survey of camps nationally in this past year to look at how many allergic reactions are actually happening in camps, how often epinephrine is being given, what the current training practices are for camp staff in relation to anaphylaxis recognition and epinephrine administration, as well as whether camps have stock epinephrine available since the changes in legislation over the past 12 months. And all that data is going to be presented at PAS and SAEM next month. So I'd like to give a special thank you to Andy Hashikawa, Michael Ambrose, and Harvey Leo, who are all my collaborators on this study. And thank you so much for listening. I'm happy to answer any questions.
Thanks, great talk. I have a question for you. So you talked about a training program?
Yeah.
Can you tell us a little bit about what you're thinking for that, for training and
Yeah.
in person, online? Camps are all over the place.
Absolutely. So our goal is to hopefully produce training materials, specifically both written materials and video-based materials, like a module that camps could then use to train their staff. And it would be mostly aimed at lay staff as opposed to camp nurses, doctors, EMTs who may already know the information.
Great. Awesome. Any other questions? Well, I sent my daughter to sleepaway camp this morning, so I just have special thoughts for the next 3 nights. Thank you very much for worrying me.